So welcome to the second case. This patient is a 62-year-old female with polycystic kidney disease. She received her first kidney already 10 years ago from a deceased donor, and now there is chronic transplant dysfunction. She is not on dialysis yet. Because of a gastric bleeding due to an ulcus, she had numerous blood transfusions last year. Her husband wishes to donate his kidney. They have 2 kids together. They both have blood group A, and she has a PRA of more than 90%. So the challenge here is that the patient is highly immunized. So let's ask Professor Klaas about the possibilities. And what are the principles? What are the outcomes? And what are the challenges in this case?
Let's look at the options for this patient. The chance to find a suitable donor for such a highly sensitized patient is not very high. The reason for that is the fact that transplantation in the presence of donor-specific HLA antibodies is associated with the occurrence of hyperacute rejection. In our laboratory, a serological crossmatch is routinely performed to check whether a patient has antibodies to a potential donor, and if so, the donor is excluded. In case of highly sensitized patients, this crossmatch is often positive, which is the reason why these patients accumulate on the waiting list. One of the triggers for the induction of HLA antibodies is pregnancy. So in this patient, it is likely that she has made antibodies to the HLA antigens which her children have inherited from the father. The consequence will be that the crossmatch with the husband is very likely to be positive. If that is the case, we have to find another solution to facilitate transplantation of this highly sensitized patient. There are several options. Our policy is to look for an alternative donor toward which the patient has not formed HLA antibodies. One option is to include the patient and the husband in our national paired donor exchange program. Every 3 months a listing is made of patients with a living donor who is not suitable due to blood group incompatibility or the presence of a positive crossmatch. Within this population it is tested whether exchange of donors will be a solution. So for this patient we will check whether one of the other available donors will give a negative crossmatch. An alternative solution is to put the patient on the waiting list for a deceased donor via Eurotransplant. Within Eurotransplant we have developed a special program called the Acceptable Mismatch Program to enhance transplantation of such highly sensitized patients. The AM program defines HLA antigens towards which the patient never formed antibodies and uses this knowledge for donor selection. Validation of all results occurs by the Eurotransplant Reference Laboratory. Once a suitable donor becomes available in one of the countries affiliated to Eurotransplant, 1 kidney of this donor will be shipped with the highest priority to this highly sensitized patient. If none of these options work, one could consider desensitization of the patient, which means additional treatment and medication to remove the existing antibodies. In Module 3, we will discuss these treatments in more detail. In this way, the patient can be transplanted with a donor toward whom originally specific antibodies were present. This approach is feasible in a subpopulation of patients, but the long-term results of such transplants are not as good as observed with the other 2 strategies. We will discuss these different points with the patient and the donor and will make a future plan. Our preferred option is to look for an alternative donor towards which the patient has not formed HLA antibodies. Important take-home lessons are that the preferred options to enhance transplantation of highly sensitized patients are either paired donor exchange or inclusion in the Acceptable Mismatch Program. If these options are not successful, additional treatment to remove the antibodies is an alternative possibility.
So we've now looked in detail at 2 interesting patient cases. So the first case discussed blood group incompatibility between the donor and the patient. And the second case, the highly immunized patient. In both cases, there are luckily options for transplantation. but there are also risks. It's of importance to make a risk-benefit evaluation, which needs to be discussed with the patient, but also with the donor. So you've also heard the advantage of living donation, and that we are very much dependent on living donation since there is a gap between supply and demand of deceased donors. So living donation, however, has a huge impact on one's life, as you can hear in the interview with the donor. In the lecture about organ procurement, you will find out the surgical aspects of different donor types.